Hello, good evening, friends. Today we'll be discussing about acute compartment syndrome. So, we'll begin with compartment syndrome is a surgical emergency where we have to save our patient from losing his limb and sometimes even life. So, it is characterized by impaired tissue perfusion, which is due to increase in the compartmental pressure, that is intracompartmental pressure in the unyielding fascial envelope. That is, it's a secured compartment, secured box with fascial envelope where there is increase in pressure due to various reason. It could be, so we'll see it ahead. So what is the pathophysiology? So there is a critical closing pressure and the compartmental pressure above which the capillaries collapse and the blood flow is arrested. So we'll repeat: the compartmental pressure above which the capillaries collapse from the transmural pressure and the blood flow is arrested. So what are the various causes of this compartment syndrome? It could be vascular cause, it could be non-vascular cause. So first of all, there is ischemia, okay, due to vascular injury resulting in ischemia reperfusion injury, and it is commonly seen in acute limb ischemia. The pathophysiology involved is there is reperfusion of the ischemic tissue resulting in reactive oxygen species induced damage, followed by increased in microvascular permeability and resulting in tissue and interstitial edema, which is progressive. The second is there is any trauma, vascular traumas, arterial or venous. If there is arterial, there is distal ischemia, then followed by ischemic reperfusion phenomena, which we seen above. In case of venous, there is venous outflow obstruction, and all these will result in increased tissue and interstitial edema. There is DVT, deep venous thrombosis, which will block the venous outflow. It will also cause bluish discoloration of the limb, which is known as phlegmasia cerulear dolens. Then deep venous harvest, that is when it is used for surgical purpose. Then intracompartmental hemorrhage, where there is intracompartmental pressure rise rapidly. So these are some of the vascular causes. Then we'll see the non-vascular causes. The first one and common one being fracture, resulting in injury to the surrounding soft tissue, hemorrhage, edema, and increased compartmental pressure. And if there is thick, tight cast for immobilization, it causes further exacerbation of the condition. Then crush injury, where we see muscle injury resulting in the increased pressure. Then snake bite, which has hemotoxic and cytotoxic venom, resulting in tissue inflammation and edema. And since there is a closed compartment, there will be increased pressure. The last one is iatrogenic, due to extravasation of fluid during any procedure. So in short, it is swelling in the compartment, trauma, or some form of ischemia due to any reason. So these are the common causes. Then we'll come to the clinical features. So for diagnosis, we need to have a very high index of suspicion. Then the common finding is pain, which is out of proportion to the magnitude of injury, and it aggravates on passive stretch. Paresthesia in the distal extremity, which is due to ischemia, which is more prone in the distal part. Then there is tense edema, so we'll find shiny skin, tense shiny skin. There will be decreased capillary refill, decreased or absent pulse, which are late signs. And then contributory factors will be increased creatine phosphokinase due to muscle damage. So how do we measure these pressures? To confirm, so most of the times these are not necessary, but these have value when the clinical finding are not uh, very suggestive, or when the patient is not of sound mind. So in such cases, or the patient is not conscious, these will be helpful. So here we have a few methods, like this is white side method, where we have a manometer connected to the uh, compartment with help of a saline and a syringe, with connection of saline air and a circuit. So this is white side method, where we will connect the needle with saline, and there will be a air chamber which will be connected to the manometer. So this is white side method. Okay. So what is the normal compartmental pressure? Normal compartmental pressure will be less than 10 to 12 mm of Hg, and compartment syndrome occurs when mean atrial pressure, the difference of mean atrial pressure and intracompartmental pressure is less than 40 mm of Hg, and diastolic BP and intracompartmental pressure difference is less than 10 mm of Hg. Other methods will be near infrared spectroscopy and laser Doppler flowmetry. We'll see some more in the coming time. So what are the sequelae of compartment syndrome? So myonecrosis, that is muscle damage resulting in renal failure, and hyperkalemia, increased potassium, which will over time result in cardiac arrest. So we'll look into the details of fasciotomy. So fasciotomy in the leg, it is more commonly needed because it is tight fascial compartment with 3 compartments, and we'll just go through brief about the anatomy. So we have anterior compartment, lateral compartment, deep posterior, and superficial deep posterior superficial compartment. So various muscles, anterior compartment we have tibialis anterior, extensor digitorum longus, extensor hallucis longus, and peroneus tertius. In the lateral compartment we have peroneus longus and peroneus brevis. In the deep posterior compartment, we have tibialis posterior, popliteus, and flexor hallucis longus and flexor digitorum profundus. In the superficial posterior compartment, we have gastrocnemius and soleus and plantaris. So we have two methods, that is the double incision technique and the single incision technique, where we can see that the red incisions are shown, which are for the double incision technique, one in the anterior aspect and one in the lateral aspect. Sorry. And then we have a single incision technique, where we see the purple colored incision, where we are opening each compartment. So in this single incision technique, which we will be giving over fibula, it will be 3 cm from the fibular neck up to 4 cm from the lateral malleolus. And the incision site, in case of double incision, it will be 1 to 2 centimeter medially from the tibial margin, and 4 to 5 centimeter lateral from the tibial margin. So these will be double incision, and we'll be opening each of the compartment. Now we'll see the thigh. In case of thigh increased intracompartmental pressure, so first of all we'll go through the anatomy quickly. So in the thigh region, we have medial intermuscular septum, lateral intermuscular septum, and posterior intermuscular septum. So anterior compartment will be having sartorius and quadriceps femoris, which will be comprising of four muscles, that is vastus lateralis, vastus medialis, vastus intermedius, and uh, quadriceps rectus femoris. Then medial compartment, which will be having gracilis, adductor longus and brevis, pectineus or obturator externus. And posterior compartment, which will be hamstrings, which will include biceps femoris, semimembranosus, and semitendinosus. So here we will be having incisions from intertrochanteric line to the lateral epicondyle above the knee joint, and we'll be incising the iliotibial band, which is on the lateral side, and anterior release, then retract vastus lateralis, explore and incise the lateral intermuscular septum, and if needed, we'll go ahead with medial compartment release, which is not very commonly used. Then we come for hand. In the upper limb, we'll go quickly through the anatomy, and which we have the extensor compartment, which has superficial and deep. In superficial, we have extensor digitorum communis, extensor carpi ulnaris, extensor digiti minimi. In the deep, we have abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, extensor indicis, and the supinator. In the lateral compartment, we have three muscles, brachioradialis, extensor carpi radialis brevis, and longus. In the flexor or volar compartment, we have superficial and deep group. Superficial will be having pronator teres, palmaris longus, flexor digitorum superficialis, flexi carpi radialis, and flexor carpi ulnaris. Then in the deep, we have flexor digitorum profundus, flexor pollicis longus, and pronator quadratus. Most commonly requiring incision is for the volar compartment or the flexor compartment, which requires the release. And this is the technique which we can see in the diagram, is the incision technique, which is extending along the medial border of the brachioradialis and medial to the biceps tendon. In case it is needed, the extensor release is given in this format, commonly used for Volkmann ischemia. So this, we had a rough overview of acute compartment syndrome. Before going ahead, I would like to discuss some diagrams and flowcharts, which is from Sebastian. So this is the diagram of pressure monitoring system, that is the intracompartmental pressure monitoring system. Stryker is the name, and it is commonly known as Stryker intracompartmental pressure monitoring system catheter, that is stick. So you can check the diagram, and this is the two incision technique, where we give anterolateral incision and posteromedial incision, and we open all the four compartments: anterior, lateral, deep, posterior, and deep superficial, posterior superficial. And we'll take care that the saphenous nerve and the saphenous vein are protected in the case of the medial incision. So we'll go ahead with the flow chart, which is very important to discuss, which is important for discussion. So if you are suspecting a compartment syndrome, we have to initiate the order set of examination, remove if there is any tight cast or constrictive dressing, discuss with the patient, our team, and then if we are having a reliable exam, that is the patient is awake and alert. If there is negative findings like minimal pain, compartment soft and compressible, no pain on passive range of movement, neurovascular intact. We'll go ahead with close monitoring with serial examination every 2 hourly by the resident, on-call resident. And if there is unequivocal positive finding, increasing or severe pain, compartments being firm, significant pain on passive range of movement, then we'll go ahead with fasciotomy of all compartment. And if there is a fracture, we'll ask for help with the orthopedic team. We'll repeat irrigation and debridement every 48 hours if needed. And later, if needed, we'll go ahead with skin graft or secondary closure. In case of an unreliable exam and the patient is obtunded or has neurological injury or under anesthesia, we'll measure the compartmental pressure with striker needle within 5 centimeter of fracture if it is associated, and it is done with a senior resident or consultant. And if the difference of pressure is more than 30 mm of Hg, then we'll go ahead with further serial monitoring 2 hourly. And if there is any discussion or concern, it can be discussed with seniors. If the pressure is less than 30 millimeter of mercury, then we'll go ahead with fasciotomy and take things ahead from there. So I hope you have understood this flowchart. That will be of very much help. And I had to discuss some points regarding acute compartment syndrome from sorry for the delay. So we'll go ahead with this. Just a quick review and some important points which we'll discuss in detail here. That in acute compartment syndrome, the early recognition and treatment is very critical to avoid limb dysfunction, amputation, and even death. Trauma, swelling, and tight bandaging were the common causes as per the Volkmann. Most common cause being orthopedic patient with a muscle edema due to trauma or reperfusion injury after vascular injury. Repeated clinical exam with consistent documentation is the crux for diagnosing reliably acute compartment syndrome. Worsening pain with passive extension is the commonest finding. Dysesthesia in the digits because the nerves are asphyxiated proximally. That's why we see that there is proximal neuronal involvement. We need a system for in place that involves multiple providers and at multiple levels. That will help us in delaying diagnosis. Compartmental pressure monitoring is an adjunct to serial clinical exams, and it is especially important when the patient has altered mental status. And commonly we use the side port needle, that is stick, that is Stryker intracompartmental pressure monitoring system, which uses side port needle technique. Other techniques are wick or slit catheter, which have continuous monitoring. Then we have arterial line setup. Then continuous monitoring has confirmed that there can be elevated pressure which are transient. So it needs repeated exams. Then we need a robust system of clinical examination and escalation, which is sensitive at correctly diagnosing the compartmental pressures increasing as in compartment syndrome, which is similar to continuous pressure monitoring. So if the patient is obtunded or intubated, compartment syndrome is suspected, then we should use Pressure monitoring, either one time or continuous, and go ahead with fasciotomy if required, if there is persistent difference in pressure less than 30 millimeters of mercury. So I hope this topic has been understood, and if any doubts or queries, they are most welcome. We can discuss them ahead. And thank you for patient listening. Keep studying, keep growing. Thank you.